I am now going to introduce our speaker for today. We have Dr. Colleen Ryan with us. Dr. Ryan graduated from Transylvania University and the University of Louisville School of Medicine. She completed a psychiatric residency at the University of Michigan and retired from the University of Louisville Department of Psychiatry in 2018. She currently works part-time at Second Chance Center for Addiction Treatment and for the Porter Stark Community Mental Health Center. She's board certified in adult psychiatry and addiction medicine. So everyone, please welcome Dr. Ryan. And Dr. Ryan, I will now turn the screen over to you.
So I'm glad to be here. And again, I'm Dr. Colleen Ryan. I'm in Louisville right now. And I did retire from the University of Louisville a few years ago. I've done some different things since then. And right now I am working at Second Chance Clinic. I'm not doing Suboxone there, I'm doing psychiatry. So I see a lot of dual diagnosis patients. So let's go over, first of all, the practice gap and supporting resources. The practice gaps are the treatment of substance use disorder and serious mental illness must occur concurrently to increase chances of success in the treatment of each one. Recognizing the presence of comorbid psychiatric disorders and initiating treatment for them will improve outcome in the treatment of substance use disorder. And our learning objectives: identify the presence of a comorbid psychiatric disorder in a patient with substance use disorder. Choose appropriate referrals for care of the psychiatric disorder. Apply strategies to support the patient's adherence to both substance use and mental health treatment, and explain the different levels of care in substance use disorder treatment facilities. Our expected outcome is integration of substance use disorder and mental health treatment will improve patient compliance with treatment, and it will lead to a more successful outcome. So first of all, I'm going to start with some statistics. I know they can be a little bit boring, but I think it's important to understand how prevalent is mental illness and substance use disorder co-occurring. And I'm not going to just talk about mental illness and opioid use disorder because that's hard to do. They're really very few. We can talk about maybe the diagnoses that are more prevalent in opioid use disorder, but really most people who have comorbid psychiatric disorders and substance use disorder are using more than one substance. So I'm going to include some other substances as well as opioid use disorder. So this is from the 2020, it's the National Survey of Drug Use in Households. This survey is done every year by SAMHSA, S-A-M-S-H-A. Normally they interview people in person. It was a little different, I think in 2020 because of COVID. So more of it was done over the phone. So it's a little hard to compare some of the statistics from 2020 to earlier versions, but I still think it's valid information. So in 2020, the past year substance use disorder and serious mental illness among adults age 18 or older was 2.2% of 5.7 million people. Past year substance use disorder and any mental illness in adults 18 or older was 6.7% or 17 million people. So to understand how they define these things, SUD, of course, is substance use disorder. AMI is any mental illness. And for them, that was anything in the DSM-5. So it could include, personality disorders, acute stress disorder, PTSD, anything in the DSM-5. SMI was serious mental illness. Now, they didn't necessarily, how they defined that was any mental illness that significantly impairs the ability to function. So I think a lot of times we think of serious mental illness more as, schizophrenia, bipolar disorder, schizoaffective disorder. But, in the NSDUH, they defined it as anything that impairs ability to function, which I think in some ways does make sense because For example, there's a lot of generalized anxiety disorder, comorbid with substance use disorder. And I think, we kind of have a tendency to say, well, it's just anxiety, but anxiety disorders can really impair functioning. So if you look at it that way, some anxiety disorders actually could qualify as a serious mental illness. If people won't go out of their homes and they can't go to work because they're that anxious, then it is a serious mental illness. So this is substance use among adults 18 and older by mental illness status, just a slightly different way of looking at it. So 47.8% of adults with serious mental illness used illicit drugs in the past year. So that's almost half. And so that's, basically saying that people with serious mental illness a lot of them are using drugs. And then 39.8% of adults with any mental illness used illicit drugs in the past year. Only 17% of adults with no mental illness used drugs in the past year. So you can see how much difference that there is. Adults with SMI had a higher percentage of illicit opioid use, marijuana use, binge alcohol use, and tobacco product use than those with any mental illness or no mental illness. So even within the people who have a mental illness, the ones with serious mental illness are using more drugs. And that is statistically significant. Again, this is from a study. They reviewed the NSDUH and found that people with prescription painkiller use disorder, which would be opioid use disorder, primarily people who were using prescribed pain, opiates, were 2.40 times more likely to commit suicide than those without substance use disorder. And those with all other substance use disorders were 79% more likely. So there's a much higher rate of suicide in people with comorbid mental illness and substance use disorders. Also, now this is from the 2016 NSDUH, which was before COVID. Among the 8.2 million adults with both any mental illness and a substance use disorder, less than half received either mental health services or substance use treatment at a specialty facility in the last year. So they're defining a specialty facility mainly as either, a substance use treatment facility, which could be outpatient, or a mental health facility. About 2/3 of the 2.6 million adults with co-occurring SMI and an SUD received either mental health services or specialty substance use treatment. So more of the people with SMI got some treatment, and that's probably because, people with serious mental illness are more likely to come to attention. But even at that, it's only 2/3. So it's like, what's happening with the other third? Among the 5.7 million adults in 2020 with a co-occurring substance use disorder and serious mental illness in the past year, 66.4% received either substance use treatment at a specialty facility or mental health services, kind of what we said before, and 33% received neither. In addition, 55.4% of adults with co-occurring substance use disorder and SMI received only mental health services. 1.6% received only substance use treatment at a specialty facility, and 9.3% received both. So, basically what this is saying is that people with co-occurring SUD, and this slide is about SMI, very few are getting both SUD and SMI treatment. Now, it doesn't mean, again, this is a statistic. So some of those people who are in mental health services, it doesn't necessarily mean that the substance use disorder is not being addressed at all. But, the question is it really being focused on? And then this is kind of the same slide, but it's people with SUD and any mental illness. Among the 17 million adults 18 and older in 2020 with SUD and any mental illness, 50.5% received either substance use treatment at a specialty facility or mental health services, And so basically half received neither service. Nearly half of adults with co-occurring SUD and AMI did not receive substance use treatment at either place. 42.3% received only mental health treatment, and 2.5% received only substance use treatment, and only 5.7% got both. And this is adolescents. Among 644,000 adolescents 12 to 17 in 2020 NASDA with the co-occurring substance use disorder and a major depressive episode, 69% received either substance abuse treatment at a specialty facility or mental health services, mostly mental health services. 66.8% of it was mental health services. Very few received both. So basically what this is saying is, the gist of it is that most people with co-occurring disorders, they're either not getting any treatment or they're getting one or the other, but not both. So we're learning more and more that it's really important to treat both. I think a lot of times, especially historically, the thought has been that if you treat the mental health clinicians tend to think if you treat the mental health issue, the substance use issue will get better. And I think substance use clinician, people treating addiction tend to think that if you treat the addiction, then the other issues will get better, the depression, the anxiety. But it really doesn't work that way a lot of times. Sometimes it does, but many times it doesn't. And sometimes whatever the other disorder is, it gets lost and not really addressed. And we know now that really you've got to address both disorders really to be successful. This is the American Academy of Addiction Psychiatry policy statement on co-occurring psychiatric and substance use disorders. And this is their recommendations. In both psychiatric and addiction treatment programs, the presence of co-occurring disorders should be expected, not the exception. So basically you might as well just assume that most of your patients have co-occurring disorders. These patients have higher medical comorbidities and their clinical course is associated with higher costs and poorer outcomes. These patients are best served in settings where treatment for both disorders is available and sufficient resources are available. These are the core principles of the American Academy of Addiction Psychiatry policy statement. The environment should be welcoming. The goal is to ensure that all encounters are welcoming, hopeful, empathic, and culturally sensitive. The program makes an effort to engage those who are unwilling to participate in recommended services or who do not fit into the available program model by providing motivational counseling. So, basically what they're saying is, especially I think in addiction treatment, sometimes many programs, have rules about what you've got to do to stay in the program. And if you don't do that, you basically get kicked out. And what they're trying to say is, let's not kick people out, at least not so quickly. You have to make a real effort to engage people, especially people with co-occurring disorders. If they're not motivated, find ways to motivate them. And I think we work more to fit the program to the patient rather than making the patient fit the program. At least that's the goal. That's the goal. As far as accessibility, the recommendation is 24-hour crisis intervention services should be available to provide assessment and intervention for both psychiatric and substance use disorders. Barriers to immediate evaluation based on drug or alcohol levels rather than clinical presentation should be eliminated. There should be programs available to meet needs without barriers or waiting lists. Patients should not have to be defined as psychiatric or substance use disorder or dual diagnosis to be accepted. Is this happening? No, probably not. I mean, this is a goal. I think the one about barriers to immediate evaluation based on drug and alcohol levels is interesting because, I know even in the past, a lot of times patients would come to the ER and, whoever was on would not want to evaluate them until the BAL was below a certain amount. And what they're basically saying is, you really shouldn't go by that, because some people actually are, able, if they're tolerant, they may be able to be evaluated at a higher BAL than other people. And you can't just say, you've got to be below a certain BAL when that may not be necessary for that particular patient. There should be programs available to meet needs without barriers or waiting lists. I wish. That's where we should be trying to go. But yeah, it doesn't really happen at this point. Integration, psychiatric and substance use disorders are both examples of primary mental illnesses, and the recommended treatment approach is integrated dual primary treatment that utilizes a disease and recovery model in a single setting. Individuals should have a primary treatment relationship with a physician or nurse practitioner that coordinates ongoing treatment interventions. And I think this is an important one because a lot of these patients do require a lot of services. I mean, they have medical issues that need to be addressed. They have their mental health issues. They have, addiction issues. And it's helpful to have one person. That's one of the biggest issues, I think, in medicine is coordinating treatment when people are seeing various providers. So you really need kind of a point person. And it says each disorder should receive specific and individualized treatment. Due to high cost and poor outcomes with this population, the recommendation is that all programs provide dual diagnosis expertise and meet the standard of ability, meaning you have the ability to treat both psychiatric and addiction issues. The program should incorporate safety screening like the PHQ-9 or suicide risk assessment. They should have the availability of an addiction psychiatrist who's credentialed, and programs should provide a range of pharmacological interventions for substance use disorders. This is the recommendation today is that there are many pharmacological interventions for substance use disorders, and there are particularly residential programs still out there that won't allow medication, and that is, definitely going against the recommendation of the American Academy of Addiction Psychiatry and ASAM and any of the addiction professionals today. Continuity, the service system must develop ways to identify patients with co-occurring disorders. And, this sounds sort of simple, but really it's easy for one or the other disorder to get lost. And these patients do fall through the cracks. And I think that's probably why a lot of times only half of them are actually getting into treatment. The system should seek out patients that are hardest to engage and most difficult to serve, such as the homeless population. The program should be responsive to the needs of the patient rather than the patient needing to meet the specifications of the program. I think, we still have a ways to go with that. It's definitely a goal. I think not just in addiction treatment and mental health treatment, but in, medicine in general, we still expect people to come to us in many ways. We still expect people to come to our offices, and, especially with the homeless population, especially with people with co-occurring disorders, there can be so many barriers to that. I think we need to do a better job of going to them rather than them coming to us always. And then once they're engaged, they can get case management, they can get services that will allow them to come to us. But we're missing the ones who are not able to get to us in the first place. So let's talk a little bit about, this is always a big question with co-occurring disorders. Is it substance induced or a primary psychiatric disorder? It can be very difficult to tell, and sometimes you never really know. But these are some of the things that I think about when I'm, seeing somebody with a co-occurring disorder. Did the symptoms precede the onset of the substance use? Of course, that's one of the first questions that you ask. Did the symptoms persist for a substantial period of time? And it's usually a minimum of a month after the cessation of withdrawal or severe intoxication. Is there other evidence suggestive of an independent non-substance induced disorder, such as episodes of the disorder occurring in childhood or in other periods of non-substance use? Part of the problem is that, you're relying on the patient for history, and people are not always good at really remembering when they had a substance-free period, how long it was, and what their symptoms truly were during that time. Also, it talks about they should be substance-free for a month at least. A lot of people, when they're first getting treatment, it's not like they just stop one day and then they have a month substance-free. It's more of a process. So it sometimes is hard. They'll say, well, I haven't been using for the last month, but really they may have been using a little bit, or they may have been using less. So again, sometimes it's hard to really get a clear cutoff period, because the DSM-5 basically says that they need to have 1 month after, substance-free to diagnose, for example, psychosis that's not substance-induced. It can be difficult to really get that. Also, family history can be very valuable. I always ask about family history. Now, you do have to take that with a little bit of a grain of salt, because so many people come in and say, my mom was bipolar and she was an alcoholic. And so you really don't know if that was an accurate diagnosis, but it's still, important to ask and document. So I'm going to talk about some of the more common things that I see as comorbidities before I talk about ADD or, let's just talk about this first. Common comorbidities with opioid use disorder. Major depressive disorder is a big one. Most people, I would probably say most people who are in early phases of substance use treatment have depression. I think a lot of, people think that once somebody is clean, using that word, that their lives are going to be so much better. You're not using, you're not on the street, but it can be very difficult in the beginning, because, they're facing reality without the substance on board. They a lot of times don't have good coping skills, especially if they started using very early. So that initial period can be very rocky psychologically, and there is a lot of depression. Now, I didn't do slides with criteria for all these, because you can look those up. You can just Google DSM-5 major depressive disorder criteria, bipolar disorder criteria. But a lot of people, it's not that hard really to meet criteria for major depressive disorder. It really only requires about 2 weeks consistently of a period. You have to have, I think, 3 or 4 out of about 7 or 8 criteria. So it's not that difficult to meet criteria. So then you have to decide, is this person depressed because they're dealing with all these issues now that they're sober? Or is this somebody who has, more of a genetic, biological underlying major depressive disorder? So what I do really is look at how much the depression is affecting the person's functioning. Even if a lot of it is environmentally related, related to the issues in their lives, if they're very disabled functionally by the depression, I will go ahead and consider treating with medication. I think therapy is important. I'm a big believer that, patients, especially early in treatment, should be in some type of psychotherapy. So I think that is important as well. But some of the common comorbidities with opioid use disorder are major depressive disorder, bipolar disorder, PTSD, generalized anxiety disorder, panic disorder, social anxiety disorder, and ADHD. In terms of medical comorbidities, Hep C is a big one, obviously, of course, in opioid use disorder, because so many of those people may have used IV, HIV, liver disease, cardiac issues, osteoporosis, infertility, hyperprolactinemia, bronchospasm, and worsening of asthma. And I think that we are, especially in the, treatment facilities, especially in the addiction treatment facilities, getting better at screening for these things. A lot of these people don't have a primary care disorder. So I know at Second Chance, we try to screen them for all of these things. And even occasionally provide some primary care services if we need to. So I do want to talk a little bit about ADHD because I have seen so much of this. I think I've seen more of this since I started working at Second Chance with the co-occurring disorder patients than I have almost my entire career. There's just so much of it in patients with substance use disorders. So I did include some of the DSM criteria for ADHD, not all of it, but so basically it's a persistent pattern of inattention and hyperactivity, impulsivity that interferes with functioning or development as characterized by inattention or hyperactivity, impulsivity. As far as inattention, I gave some examples. You've got to have 6 or more of the following symptoms for at least 6 months. They're actually, I think in the DSM, there are more symptoms than that. These are just a few. Failing to pay attention to detail, not listening when spoken to, not following through on instructions, losing things, forgetful. There's a whole list. Hyperactivity, 6 or more of the following have persisted for at least 6 months, fidgeting, squirming, running about, climbing in situations where it's inappropriate, interrupting others. I'm going to show you the adult ADHD rating scale in a minute that has a lot of these on it. Theoretically, they should have been diagnosed as children to meet criteria historically. They should be diagnosed as children to really meet criteria for adult ADHD because we've always thought of it as something that starts in childhood. If there's no childhood history, then you always kind of wonder if it's really the long-term use of the substance that might be causing some of these symptoms. But there is some change in that thinking, and I'll show a slide late in a few minutes about that. Also, we don't really say ADHD so much anymore. In the DSM-5, it's really ADD, and then you say that it's either the combined presentation, inattentive and hyperactive impulsive, or predominantly inattentive and predominantly hyperactive impulsive presentation. Studies have shown that 1 in 6 adults seeking treatment for substance use disorder has ADHD. I mean, that's a lot, really, I think, and I could believe that based on what I see. And a lot of these people were diagnosed in childhood, but for whatever reason, they didn't continue their stimulant, or maybe they were diagnosed but not on stimulants. Comorbid patients also reported more risk-taking behavior and a higher rate of other psychiatric disorders compared to substance use disorder patients without ADHD. So, you can see the more impulsivity and higher rate of psychiatric disorders. So the estimated childhood prevalence of ADHD, I'm still saying ADHD because we tend to use that, is 4% to 7%. It's estimated that between 15% and 65% of these persisted to adulthood. That's a really wide range. I think it's more than 15%. The estimated prevalence of ADHD in adults is 2.5%. So this is kind of a little bit different way of thinking about it compared to how we thought about it historically. Now we're sort of beginning to think that adult ADHD may not just be a continuation of childhood ADHD. A substantial number of adults do not give a history of ADHD in childhood. There may be 2 separate syndromes with different developmental trajectories. So that's a theory. Also, a lot of times with patients with substance use disorders, many of them came from, families with substance use disorders. So I think a lot of them probably had ADHD in childhood, but it wasn't diagnosed. I find that a lot when I do, these evaluations, people will have these symptoms. I'll say, well, how did you do in school? Were you able to sit still? And they have a lot of the symptoms in childhood, but it just wasn't diagnosed. Symptoms, and again, failing to pay attention to detail, difficulty organizing tasks and activities, excessive talking or fidgeting, difficulty relaxing, overworking, forgetfulness, distractibility. Historically, it seems like girls are sort of underdiagnosed because they often have more of the inattentive symptoms, not so much the hyperactivity. So it's just not as obvious to parents and teachers. So this is a study where the authors analyzed some commercial healthcare claims from almost 3 million adult and adolescent patients. 47% were female. They compared the risk of substance-related events during times when the patient was taking medicine versus times when they weren't. So this addresses the question of, if you treat somebody with a stimulant when they're young, some people have feared that that would increase the chance of a substance use disorder later in life, because you're treating them with a controlled substance, you're treating them with a stimulant. Does it make it more likely that they're going to abuse that? So what they found is that male patients had a 35% lower odds of concurrent substance-related events when receiving medicine, and female patients had 31% lower odds of concurrent substance-related events when receiving medicine. So they actually had fewer substance-related events like, relapsing, using, when they were receiving medicine as opposed to when they weren't. Male patients had 19% lower odds of substance-related events 2 years after medication periods, and female patients had 14% lower odds of substance-related events 2 years after medication periods. So it actually extended even for the next couple of years. These are some of the clues to the presence of ADHD. I'm going to show you the ADHD rating scale, which I use a lot, in just a minute. One is using the adult ADHD rating scale. Now, it is a self-report scale. So, there are always some issues with that. It's self-report. And you can always say, well, if people want to be on a stimulant, they're going to overrate these things. I don't think that's necessarily true. You kind of have to know your patient. But I think it's a good indicator. I hear this so much, at the clinic. Paradoxical response to methamphetamine. A lot of these people, now you would think that somebody with ADHD would kind of lean toward abusing stimulants, and that would be their drug of choice. That's not always true. I do see people with primary opioid use disorder who, have ADHD, and I think they're using the opioids partly they're trying to calm their mind. One of the biggest complaints that people with ADHD have is the racing thoughts, just not being able to shut their minds off. And I think that may actually be more true of adult ADHD than it is childhood. So I think they're probably using the opioids to try and, calm their mind. But some of them do use methamphetamine, and they will say, meth doesn't affect me the way it does everybody else. It's really weird. They say, if I want to go to sleep, I use methamphetamine, or I use meth to be able to slow my thoughts and get things done. Just an indicator. I've heard that a lot. Another clue might be the patient's sober, but they're not really progressing. Not being able to hold a job. This is one of the big things I see with adults. They can't hold a job. They'll say, I just get bored after a little while, or, I just kind of decide to not go. They make poor decisions. They're kind of impulsive. They have problems in relationships. A lot of them have moodiness. And there's a big overlap with bipolar disorder, which I'll talk a little bit about. But moodiness, impulsive, hard to get along with, not living up to their potential. Those are some of the things that I see in adults. So what about treatment? A lot of clinicians will start with Wellbutrin, especially in patients who have a substance use disorder. And I understand the reasoning. You're trying to avoid controlled substances. I just honestly, for people who truly have ADD, and it's, moderate to severe ADD, I just honestly don't find Wellbutrin that useful. I do sometimes try it, especially if they have some mood symptoms along with it. But I really haven't found it that useful in the long run. Now I do use Strattera sometimes. That's the other thing, Strattera is actually pharmacologically somewhat pretty similar to Wellbutrin. So usually if they're not going to respond to Wellbutrin, they're not going to respond to Strattera, but I do try it sometimes. Again, it's not a controlled substance, so it's a lot easier to prescribe. And if you do have somebody that you're really concerned about them abusing the controlled substances, that is an option. If that doesn't work, and I'm really, I really feel confident in the diagnosis, and I feel like the ADD is really impacting their lives, like affecting their work, affecting their relationships, I will treat with a stimulant, a controlled substance. It's got to be very closely monitored. And people would say to me, why are you treating somebody who's abused methamphetamine with a stimulant? It seems a little counterintuitive, but my philosophy is that if you've made a diagnosis, you need to at least try to treat the patient with what it is they actually need. So at Second Chance, I do have people who are on Adderall. I have a couple of people on Ritalin. I tend to use Adderall more. And I have had, I think, decent success with people who have abused meth, and yet I feel that they have ADD, with getting them on a stimulant to treat the ADD and having them stop the meth. It's not 100%. I mean, I've had some people who even on Adderall ended up continuing to abuse meth, and then I had to pull them off the Adderall. But I've had a lot of people who were able to respond to the stimulant, stop using the meth, be compliant with their Suboxone treatment, and it's been very good to see. But I also work in a place where I can monitor very easily. We can get the POC testing, point of contact testing, very easily, and confirmations. And that's really a key. If you're going to treat somebody with a substance use disorder with a controlled substance, you've got to be able to get the more detailed urines periodically. The little day-to-day cup test will give you kind of a superficial overview. But if you want to distinguish whether somebody is using your prescribed stimulant or methamphetamine, you've got to send it off for a confirmation. So if you don't work in a place where you don't have that ability, then, it's really hard to treat people with a controlled substance. You probably need to refer out to some place where there is an addiction psychiatrist or psychiatric nurse practitioner who has a DEA. It's not, we'll go into that later. It may be difficult to distinguish from bipolar disorder. There is a lot of comorbidity with ADD and bipolar disorder, and a lot of people have both, which makes it even trickier. This is part of the adult ADHD rating scale. All of it didn't come out on the scale, I don't think. But this is free. You can Google it. It's the adult ADHD rating scale. You can download it. You don't have to have special permission. I use it all the time. Again, it is a self-report scale. And there's really not it doesn't say, oh, you've got to have so many in the gray zone to qualify. You basically look at it and see the first part of it that you can't really see very well is more the inattentive symptoms. And then the last part of it is more the hyperactive symptoms. So theoretically, the more they check the things in the gray zone, the more likely they are to have ADD. really, if you wanted to be very thorough about it, the best way to diagnose it is to send somebody to a psychologist for psychological testing. And they can do a really, in-depth testing battery that's very accurate. The problem is finding a psychologist who does testing these days is hard to do. And a lot of insurances won't pay for it. It's expensive. I don't think I've ever been successful getting Medicaid to pay for psychological testing. So I base the diagnosis on my evaluation, their history, and the adult ADHD rating scale. And I will say, of all the comorbid things that I've treated, I found people most grateful when their ADD is treated. I have had people come in and tell me, just the other day, somebody said, if I had only had this when I was a child, my life might have been totally different. People have said, I think I might not have gotten into substance use if I had had this, because they were trying to medicate their racing thoughts. They're not being able to get things done. A lot of people use opiates for energy, amazingly enough. I can't imagine that, but I hear that a lot. I use opiate because it gives me energy to get my housework done. So I do think that this is a big one to treating. This can really be helpful to patients in a way that, sometimes surprises you and them. So again, ADHD, as far as what goes with ADHD, the highest comorbidities with ADHD are major depressive disorder, generalized anxiety disorder, bipolar disorder, and substance use disorder. They can have all of them, and it's very hard to tease out what's what. I personally, if I really think somebody has ADD, I like to treat that first, because what I have found is that even though they have a lot of anxiety, a lot of times the anxiety is because they're not getting anything done. The anxiety is because they're not working, they're not successful at work, they're frustrated because they can't get their housework done. And sometimes when you treat the ADD and they're actually able to function in life, their anxiety gets a lot better. So the rates of ADHD comorbidity and bipolar disorder have been estimated between 9.5% and 21%, and rates of comorbid bipolar disorder and ADHD at 5.1% and 47%. You can see the wide range there. So basically what it says is a lot of people have both, and it can be very tough to figure out whether it's one or the other or both. Possibly the most common comorbidity in ADHD is substance use disorder. Studies have found that ADHD in individuals with substance use disorder is associated with earlier onset of substance use, increased likelihood of suicide attempts, more hospitalizations, higher rates of polysubstance use, less likelihood of achieving abstinence, and lower rates of treatment adherence. So to talk a little bit more about bipolar disorder and substance use disorder, just going back a minute to bipolar and ADD, I find that a lot of people with ADD have a lot of moodiness. They have a lot of irritability. And so, sometimes I'm trying to sort out, is this, because you can have irritabilities in bipolar disorder too. Some people have more of an irritable mania or hypomania than the grandiosity that you normally think of. But I have found that people with ADD can have a lot of moodiness, a lot of irritability, and sometimes treating the ADD will help actually with the moodiness, and they get along better with others. But sometimes, you figure out that they also have some components of bipolar disorder. So there was a systematic treatment enhancement program for bipolar disorder. This was a study looking at the treatment for bipolar disorder, and it included 3,750 bipolar subjects. And they found that a history of addiction increased the risk of switching into manic, hypomanic, or mixed phases after depression. They didn't come to a lot of conclusions because there was so much variation in how bipolar disorder was treated. But they did find that In bipolar disorder comorbid with illicit substance use disorder, lithium and valproate were effective for mood symptoms and may reduce substance use, probably as an indirect effect due to mood stability. And the neuroprotective agent citicoline reduces cocaine consumption. So citicoline is kind of it's a precursor to phospholipid phosphatidylcholine, which is a chemical that's basically neuroprotective in the brain. And it has been used some for things like, neurological disorders that are degenerative. The studies are really sort of mixed about whether it's really effective. It's not a prescribed medicine. I actually looked it up. You can buy it on Amazon, like you can buy most things these days. And actually, I haven't seen a lot in the literature about citicoline with cocaine, as far as, more studies really looking at whether it reduces cocaine consumption. I mean, I hope it would, because we certainly, if it worked for cocaine, maybe it would work for methamphetamine. I definitely think we need more studies about that. Overlap between bipolar disorder and ADHD. They both have racing thoughts. They both have irritability, moodiness, hyperactivity. Bipolar disorder usually, though, is a little more cyclic, with mood disturbance the predominant feature, while in ADHD, it's really the lack of focus, the difficulty getting organized. The moodiness is kind of secondary, but again, it can be difficult, and a lot of people have both. So you might end up, for example, having them on, your stimulant and some sort of mood stabilizer. I use Abilify a lot. And so if I've got somebody on a stimulant and they still have some symptoms of moodiness and irritability, and maybe even some racing thoughts, I might add a mood stabilizer like Abilify. It can be difficult to diagnose bipolar disorder without a period of sobriety, especially if the person's using stimulants. And this is hard. If they're using methamphetamine all the time, they look, they're going to look manic. And I do think, we think of methamphetamine as fairly short acting, but I think a lot of these substances hang around way longer than we really think they do. So that does complicate things. Stimulants may precipitate a manic episode in someone who is vulnerable. And this happens a lot, there is a fair amount of people heavily using meth can be psychotic. They get really paranoid. There's meth-induced psychosis. If the patient has manic or psychotic symptoms, technically you try to wait 30 days before you call it non-substance induced. You try to have a 30-day period that they're substance free. And then if they still have psychotic symptoms after that, you begin to think that it's not just substance induced. It may be that they had a vulnerability, an underlying vulnerability to a psychotic disorder that the methamphetamine has exacerbated. But, if they're really, really psychotic and out of control, even if it's less than 30 days, you sometimes need to treat. You need to treat with an antipsychotic. They may need hospitalization. I do think that sometimes they don't respond as well to antipsychotics when they still have the meth on board. But if they're really extremely psychotic, sometimes the medication can sort of calm that down, even if they're still in that, 30-day period when there's some methamphetamine on board. And again, if you're using some of these questionnaires, like the mood disorders questionnaire, be sure to ask them to try to rate their symptoms based on a period of sobriety if they can. I mean, a lot of times it's hard for them to remember a period of sobriety, but try to have them rated based on a period of sobriety. I have a lot of people who come in and say, my moods are all over the place, especially people who are newly sober. I don't jump to a bipolar diagnosis with that. And a lot of patients have been told they're bipolar. And I really take that with a grain of salt. They may have been using, they may not have told the clinician who diagnosed them that they were using. I think there's a lot of overdiagnosis of bipolar disorder in this population. Okay, let's talk a little bit about generalized anxiety disorder. Everybody's anxious. I see so much anxiety But, again, and I think sometimes as a society, we sort of downplay anxiety as a serious mental illness. Everybody's anxious. We all have stress. This is really it's like anxiety on steroids. It's not just your average everyday worry. These people are really, if you meet criteria for generalized anxiety disorder, it's significant. It's really impacting your life. It may be keeping you from going out of your home. It may be keeping you from working. So, I'm talking about a kind of anxiety that's pretty disabling for the person. So this is part of the criteria. Excessive anxiety and worry occurring more days than not for at least 6 months about a number of events or activities. The individual finds it difficult to control the worry. The anxiety and worry are associated with 3 or more of the following 6 symptoms, and it's got to be present for more days than not for the last 6 months. So we do actually have criteria for generalized anxiety disorder, and that some of the symptoms: restlessness, keyed up, being easily fatigued, difficulty concentrating or mind going blank, irritability, muscle tension, sleep disturbance. I think, there probably are actually more than that, but those are the ones in the DSM-5. And I'm not sure that criteria really reflect, how disabling people with severe anxiety feel. So then you get into how are you going to treat it? A lot of these people have been on benzos. You've got to be very careful about benzos in benzodiazepines, such as Valium, Xanax, Klonopin. You have to be careful of that with people with addiction, obviously. And yet I think it's a mistake to not treat it, because if somebody's really disabled by anxiety and they're not functioning, it also is a trigger for relapse. So, generally the American Psychiatric Association recommends that you start with low doses of SSRIs for anxiety. That can be effective. Psychotherapy can be effective. But, I do think it's important to acknowledge that it is a disabling and can be a serious mental illness, and that it does need to be treated. A lot of these patients will say, well, I've been on citalopram, I've been on, this or that. They probably didn't give it a fair chance. I do have a few people who are on low doses of benzodiazepines. It kind of, it's a last resort, but, if it gets somebody out of the house, I'm willing to do that on a temporary basis. Again, you've got to be really careful with some of the medications for substance use disorder, like Suboxone, combining those, and you have to really monitor. You have to get confirmations and make sure they're not also using other benzos like Xanax or Valium. So you really have to be in kind of a specialized place to be able to do that. But it is important to address it and treat it. There is a correlation between social anxiety disorder and alcohol use disorder. And, a lot of these patients who are recovering, especially early in recovery, it's hard to know whether, because of their use, their neurotransmitters are out of whack that it makes them more anxious, or if they just don't, a lot of them, they're not used to tolerating feelings. They're just not used to tolerating affect and feelings, and they have poor coping skills because they've been self-medicating. So, part of the goal of therapy is to help them work on coping skills. On the other hand, I don't think you can necessarily wait for somebody to develop coping skills if they're very disabled by anxiety. So my goal is always to treat, but to get them into a therapy where their goal is to work on managing the anxiety. I'm not going to spend a lot of time on this. I just threw this in to kind of remember that there is a neurobiology to anxiety disorders. Basically, the hypothalamus is involved. It secretes corticotrophin releasing hormone, which via the pituitary hormone adrenocorticotrophin induces production of cortisol. And then you get activation of the sympathetic nervous system that leads to the fight or flight response. Stress of extreme nature or prolonged duration is among the most important risk factors for many diseases, including major depressive disorder and PTSD. Basically, what this slide is saying in a very technical way is sometimes what happens with people who have severe anxiety disorders is that the fight or flight response doesn't turn off, or it gets activated in situations that are, really not extreme, but, more minor. And so basically you get all the, the norepinephrine release, the body response, the fight or flight response in situations where it doesn't really need to happen. Okay, at the time here, I want to talk a little bit about PTSD. Again, a lot of PTSD in these patients. A lot of it is from childhood. A lot of substance use disorder patients grew up in chaotic, abusive households. Not all, especially with opioid use disorder. There are a number of patients who really had pretty stable childhoods and pretty stable lives, but they were prescribed opiates for whatever reason for long periods of time, and that's how they became addicted to opiates. But I still find, even in opioid use disorder, a lot of PTSD, a lot of trauma. And sometimes it's not just childhood trauma, because when people use substances, they get involved in, they make bad decisions. So they get involved in situations where they might be traumatized, they might be attacked, they may have witnessed things. They may have witnessed things if they've been in prison. They may have witnessed violence. So just, being involved in the substance use world can sometimes cause trauma. But just to review here, post-traumatic stress disorder, exposure to actual or threatened death, serious injury, or sexual violence in one or more of the following ways. I did not list all the ways. You can look that up in, criteria. It's like witnessing violence, experiencing it, being, fearful that you're going to die. There are a number of them. Presence of one or more of the following intrusion symptoms associated in the traumatic event, beginning after the traumatic event occurred. And there's a list of intrusion symptoms, like intrusive thoughts, where you're just kind of, going about your day, and suddenly a thought, a memory of the event will pop into your head. Nightmares would be considered intrusive events, flashbacks, things like that. Persistent avoidance of stimuli associated with the traumatic event. People who can't watch certain TV programs because of the violence, or people who avoid relationships, maybe, or avoid anything that reminds them of the traumatic event. And that can be pretty extreme. That can be pretty life limiting if you have to avoid a lot of things. A lot of times, negative alterations in cognitions and mood associated with the traumatic event. And what I was going to say is that a lot of times these things don't really come to light until you get somebody in, addiction treatment, and then you kind of discover they're trying to medicate all of these symptoms. So again, PTSD is a big one that I see in at the clinic in addiction treatment. Now, there's not a treatment for PTSD. And I think sometimes chronic PTSD, it seems like with chronic PTSD, where maybe the event occurred during childhood, you might not see as much of the intrusion events. You maybe see more of the avoidance. But a lot of times, in terms of treatment, medication treatment, I look more at the symptoms, like, do they have a lot of depression? Do they have a lot of anxiety? Do they have a lot of mood lability? So I try to treat those symptoms, but there really is not a medication for PTSD. Psychotherapy can be important. There are a lot of new therapies being explored for PTSD. I don't know if you've read much about using, there's some research actually about using hallucinogens to treat PTSD. I think it's pretty experimental. And I certainly don't do it. It's got to be in a very, very specialized place that's being explored more in New York at some of those treatment facilities. But it's important to recognize, get treatment for it, get the person into therapy with somebody who has some experience with PTSD. Approximately 57% of patients with lifetime PTSD have an alcohol or drug use disorder or both. Of those who present for treatment, PTSD comorbidity is common, estimated to be about 40%. And I would agree with that. That's pretty much what I see. So this was an interesting study that looked at 28 random controlled trials. This is a meta-analysis. So they looked at, in the literature, at some randomly controlled trials. Generally, the treatments fell into either a trauma-focused treatment where systematic trauma focusing was occurring, like re-experiencing some of those treatments, versus non-trauma focused treatments that address substance use disorder and PTSD without going into the real specifics of the trauma. The non-trauma focused treatment integrated PTSD and substance use disorder treatment in various ways. It just didn't get into a lot of depth about the trauma specifics. They compared trauma focused treatment to manualized substance use disorder treatment, substance use disorder treatment as usual without the manualized treatment, and no or minimal treatment. And then they compared non-trauma focused treatment to the same things, to the manualized substance use disorder treatment as usual and no treatment. And what they found basically is that all of the conditions were associated with statistically significant small to large magnitude reductions in PTSD and substance use disorder treatments. I think what that means to say is some of that was not carried over into post-treatment or follow-up. So trauma-focused treatment showed significantly larger effects on PTSD at post-treatment than the others, but it didn't carry through to longer-term follow-up. Trauma-focused treatments did not differ from the others on measures of substance use disorder. When trauma-focused treatments were compared with manualized substance use disorder treatments, there were no significant differences on PTSD at post-treatment or follow-up. And basically, the manualized substance use disorder treatments actually did better with the substance use disorder components. So, and then it says non-trauma focused treatments did not differ from all comparators on PTSD at post-treatment or follow-up. Basically what this kind of is a little bit contradictory in that what it's sort of saying is that all the treatments made some difference. It didn't always make a difference long-term, but that any kind of treatment seemed to be somewhat helpful. So, you know, on the one hand, we're saying these people really need specialized treatment where they can get both substance use disorder treatment and, you know, mental health treatment. And I do think that's true, but you may not have to, you know, have like a PhD in psychology or an MD or whatever, or specialized training in CBT or, you know, exposure therapy. I do think the connection with the therapist and the support makes a big difference. Patients know if you're really invested in them. And I really think the quality of the therapeutic relationship sometimes gets underestimated. And I really think that's kind of what this is about. I mean, if you're really invested in the patient and they know that you care, you can make a big difference, whether, you know, no matter what kind of training you have. It's not that difficult to learn basic motivational interviewing techniques and to learn some basic CBT and exposure therapy techniques. So, you know, again, some treatment is better than no treatment at all. So that is pretty much what I have. Basically, as far as conclusions, treating substance use disorder, including opioid use disorder and comorbidities, whether medical or psychiatric, is treating the whole person. And I think that if you if you're really invested and engaged with the person, that's what you're doing. I mean, that just is what you're doing. You're treating the whole person. There are many associations between substance use disorder and co-occurring disorders, but causation is unclear. And I think sometimes you can get too caught up in whether is the substance use or psychiatric. They're all mixed in there together, and you've got to treat both of them. Every patient is different. Make the treatment fit the patient rather than making the patient fit the treatment. And, I have found that if you can hang in there, sometimes the most difficult patients can be your greatest success stories. So that is what I have. So we might have time for a couple of questions.
Firstly, thank you so much, Dr. Ryan, for your time and for this information. I personally found this to be enlightening and helpful. And thank you to the people who have been engaged in asking some questions. So I do have a couple questions on the side, as well as one longer one that I think will make a great case example that we'll save for next week. But I am happy to pose a couple of the questions in the chat. And if you have questions, please feel free to go ahead and put them in the chat, and we'll try to get to them today if we can. And if not, we'll do them next week. But a couple of the quicker ones from Dr. Nichols. One of those was, is there an advantage to methylphenidate to sort out street meth use from the prescription?
I haven't really found that. I mean, when I get a confirmation, basically it tells me if the patient is using methamphetamine and what the level is and versus amphetamine. So, I mean, that I haven't found that methylphenidate gives me any advantage myself. So I tend to use Adderall more.
Thank you. And then the other one was kind of when we were talking about testing. Dr. Nichols also mentioned vocational rehabilitation, and was curious if that is something that you've seen as an option for people to go to for testing and evaluation.
Yeah, it is. That is true. I mean, I think, these patients really need case management. And usually in our facility, case management will try to get them into vocational rehab. Sometimes I have found vocational rehab is hard to get into. There may be a wait list, but case management, you've got to address, they've got to have a place to live. Work is one of the most therapeutic things that, people can do in order to stay stable. So voc rehab can be helpful. Now, my experience with voc rehab, and maybe she can address this too, is they'll do more testing about what the patient, what the skills are and what they can do well. I don't know that they'll really address the ADHD issue. So I don't know if she's on there, maybe she could answer that question. Maybe she's had more experience with that than I have.
Hi, I don't know if you can hear me.
Mm-hmm.
Yeah, I can't say I have experience that it actually happened, but it's always discussed. Send them to voc rehab, get the assessment, confirm the diagnosis, while they're also trying to figure out things like job opportunity, what a good job fit. But we're just trying to think through, with the navigators and case management, ways to help support that, especially if there are clinics that don't have that in their assessment workflows with the.
Yeah, that's a good point. I have found that sometimes you don't get into voc rehab right away. I guess my feeling is somebody wants to work where they're failing at a job they have, then I like to go ahead and try and treat. So.
Yeah, thank you both for your comments. I also saw a comment from Robin that said that voc rehab often can make referrals for testing, but not test themselves. And just from previous roles that I've been in, I found that to be the case as well, as that, someone was working with voc rehab normally. So you've got the time to get into working with voc rehab in itself. And then often there's some additional time to make that specific referral where it is, in terms of like funding piece is paid for by voc rehab. It takes further time to actually get into someone that can evaluate that. Uh, I also had a question that was posted from Robin. It said, "Do you see any concerns with long-term use of medications for ADD?" You mentioned if you're diagnosed in childhood, then that could be, a lifelong, 50 or 60 years on medication.
Well, I think that probably it's useful for people at some point to, try and taper off. Some people do grow out of ADD. And so you're not really going to know that unless you maybe have a trial off the medicine. So I think it does make sense to try someone, if they've been treated as a child, maybe try them off the medicine at some point. But, I guess my feeling is if they're not functioning well and they need the medicine, then they need it. And I would go ahead and treat. I think you do have to monitor the way you do any medication, and check liver functions and labs periodically. I do, there is an issue. Some of the patients that I treat with stimulants, I have to watch their blood pressure. You've really got to watch blood pressure and heart rate. And I've had to, lower the dose or take some people off because of that. So medical comorbidities, you do have to look at as people get older. They're going to have some heart disease. So you've got to think about using a stimulant in somebody with heart disease. So you do have to watch those things.
That makes sense. Thank you. Let's see. The next one might be, or was a kind of a comment, but related to question, but it's talking about a barrier related to the case management portion. Just it says that the state often says that there have to be therapeutic services in place in order for the provider to be reimbursed. So many times you need case management portion first in order to resolve the immediate crisis or basic needs, and then working with the therapeutic provider. And Michelle, please feel free to Cunningham if there was a specific additional comment or question that you had within that to come off mute. But I just wanted to make sure that we got to one of your comments and questions today.
No, I was just agreeing with her that, case management's a huge portion of what they're needing, but the barrier with getting them the case management service to link them to, let's just say Voc Rehab or one of the other providers, is that in order for a provider to be paid for that case management service, they have to go ahead and have a therapeutic layer open, for example, for that provider to get reimbursed. And a lot of times you have people that are be like, well, I need to get this, taken care of, or I need to get, into, working because I can't pay my bills. And, that, hierarchy of, basic needs need to be met because they're in that crisis mode. So they don't want to commit to themselves of, going inpatient because, their LG&E bill is getting cut off. And, they're in that immediate, this needs to be resolved. I need help getting this. So they put off doing the other things that maybe would benefit them as far as their treatment, or, actually talking to a therapeutic provider to maybe, help them with some of that, trauma that they've experienced that's causing them to then, utilize whatever source that they're utilizing. So it's this, circle, and I don't know, it's almost like a tornado. You gotta help them get to the things that they need first, resolve that crisis, help them with a little bit of that stability for them to then have that buy-in of, yeah, I want to access this program, or I want to access this therapeutic provider that's going to help me, or whatever the case may be. But we're almost putting the cart in front of the horse, saying, well, they have to have this before they can get you. Well, they need you to be able to access a lot of these other, resources or programs or services, or, whatever that need is, so there's always that catch-22. And a lot of times they won't buy into, doing the program or getting that help, or, completing this, assessment or whatever the case may be, because they have this dire, need that they need to have taken care of, but they don't have the resources, or they don't have the linkage, or, whatever that piece is that, is missing for them. And that case manager can help them get those things resolved. But a lot of times people won't be able to work with them until they have those other, providers in place. So to me, it's almost kind of like you're doing a disservice. Yes, they need that case management, and that piece definitely needs to happen before even saying, well, they have to have Voc Rehab, or they have to have, therapy open, or they have to have a treatment program, in place. because a lot of times they don't know how to access those, or they don't know how to go through all the hoops to get their insurance to pay for it, or they don't know how to get, their doctor to write a, referral. I mean, there's like a whole lot of things that case management piece can help. And I've ran into that with clients. So that's the reason why I had put that in there, is that those are things that in a realistic world is happening. And that we're seeing people aren't accessing the care that they need because of those issues. That red tape.
Yeah,
piece.
I agree. I think that's how you engage a lot of these difficult people initially, is with case management. But I don't, that might be something like, I work with the Kentucky Society of Addiction Medicine, and I know we try and work with legislators. So maybe that's something I could bring up to them.